I had a question for Kidrit. How do you reduce the femoral neck?
Great question.
Oh, sorry.
Closed or open?
So say you can't get it closed, and so you have to open it. Do you have like any special technique in reducing it?
I think your medial calcar is going to be your best place to start. And like I said, I would only open reduce a femoral neck if I thought I had a really good medial calcar read.
Okay.
Getting contralateral films is
So
really...
you won't even open it if it's really comminuted in the calcar?
I don't think it's going to help you unless there's a read in the back that you think you can go after.
Okay.
And then I think contralateral hip films are paramount to figure out what your neck shaft angle is and rotation alignment.
I don't know if you've ever used it. I love going anteriorly, and I use a Young Bluth because I can dial it in. Now you got to be careful because you start getting too many screws. And in our study, and I don't think most of the studies had a higher AVN rate when you open it.
Yep.
I don't know if it's the lateral circumflex. I always think it's more, these are the ones that are probably more energy, and therefore there's higher AVN rate.
Yep.
And I think the key is don't go over the top of it.
And then I'm a big fan of mini plates too.
Mini plates. I hate mini plates, but that's probably because I don't know how to use them and they're too small. I don't see them. But
I have small hands.
there you go. Any other questions on that one? For Joe, I didn't see any ball spikes. So I love ball spikes anteriorly. Do you use that much, or you tended to opening and doing those kind of mini open things?
Yeah, so there was an example, perhaps you fell asleep. There was.
With you, yeah, it probably happened. I was snoozing a bit.
Right? Didn't we all see
Anybody
a ball
else
spike?
see a ball spike on Joe's?
On the lateral cortex, everybody agrees.
Okay, nobody saw it.
So, yeah, I'm not a big fan of just percutaneously pushing something through the front of the hip. So I'd much rather go from the side, from the lateral side, and reach around. Probably disrupts, peels up a little bit of tissue, but I'd hate to stab the circumflex or the femoral artery or the things that you often injure.
Yeah, I guess I don't have that problem, but I can understand you liking the reach around. Amir. Yes. So this might be me, but sometimes you got these horrible fractures, intertroch, subtroch, femoral neck all in one. I think those are easier. If I see a simple subtroch, I'm like, crap.
Yeah, I think once you have the lesser trochanter off, I think it makes it a little bit easier because iliopsoas basically pulls it away. And so in a lot of those cases, actually, you get sag of the proximal fragment, where the proximal fragment actually goes, toward the floor or posteriorly. And in those cases, I didn't show it in this because I wasn't talking about neck fractures or intertrochs. But in those cases, I'll take a shank spin and put it in the medial part of the neck, medial inferior part of the neck, and then pull actually proximally and proximally and medially. And that actually gets rid of that whole sag and holds it in position. And then what I do, I also didn't show, is I take a vaginal tape, which is actually sterile, wrap it around it and bring it off the table and then tie it to the table. And that actually causes it to stay because that, tying it to the table, it never gets tired, doesn't have to go for a smoke, there's no breaks, right? It just sits there and holds it reduced. So that's how you get rid of the sag if you need to.
No, that's good. I think the point, and I think everybody kind of got this, and I think it's hard, if you're in private practice, maybe like Joe, to have someone that can continuously hold it. But when I see the non-comminuted subtroch, I know I've got to put a joystick in, usually posteriorly, because I got to control the varus, and then I have to have a ball spike anterior to hold it down. But I can't hold that and do the nailing at the same time.
And so a lot of those cases where, fellows knows, if I think I'm going to have a problem, I go lateral decubitus right away and I make an incision and reduce it. I think it's a lot easier to do it that way. It's a lot faster. You don't have that much actually, I don't think you lose that much blood supply to the fracture site, and you can get the reduction perfect every time.
Right.
When you put
you
the
just
patient
start that position.
I just start lateral decube if I'm worried. And when you put the patient on the fracture table, the harder you pull, the worse it gets.
Yeah.
Whereas in lateral decubitus position, you just move the leg to the fracture site, the distal fragment to the proximal fragment. It's a lot easier. You just have to worry about rotation. It's a little bit harder to gauge rotation in lateral decubitus position. You just have to make sure that's okay.
Yeah, I'd like to agree with Amir that particularly those subtrocks with the long spike, big spiral, just put them lateral, open it up, reduce it, put your nail in. It'd be a whole lot easier than trying to pull on it with a traction.
Yeah, and I think the hardest part of the lateral decube is really the lateral view of the neck. And so the trick for that is you essentially over-rotate. So you move the pelvis, unlike a total hip, where you want the pelvis to be straight up and down, you move the pelvis over a little bit. So it's facing, like, patient's laying a little bit more forward, and it's easier to get a lateral of the neck that way.
On a beanbag, right?
On a beanbag.
So any other question? Oh, we have one.
Question about the four-part inner trochanter where head and neck is one piece, shaft, lesser troch, greater troch, and the greater troch's comminuted. Does that change how you choose your implant? Does that particularly change your start site since your start site is now in multiple pieces? I'm just curious.
Does it change it?
I actually don't worry about any of that. I just think about the neck shaft angle in that case. You know what I mean? So basically, I'm looking at what Kudrit says is really important. You get an image of the contralateral side and look at the neck shaft angle, and actually save that on the on the C-arm, and then reconstruct that and just span the whole thing with a nail. I don't worry about the if the whole thing is exploded proximally. All I care about is the neck shaft angle and procurvatum, recurvatum.
Yeah, do you agree, Joe? Yeah, so to me, when they're that comminuted, I like those because the soft tissue kind of holds it in place and it's easier to reduce. Ted, are we done? Come on up, Ted. Thank you, everyone.
Thanks, guys.